Now that you have an understanding of the key steps to a successful resuscitation, you will learn more about respiratory arrest. Respiratory arrest may sometimes precede cardiac arrest. Thus, cardiac arrest is sometimes preventable by addressing respiratory issues. In this module, you will learn about airway anatomy, respiratory arrest, artificial ventilation, and advanced airway techniques. You will also have an opportunity to learn about COVID-19 precautions and concerns. Let's get started. It is important to know basic breathing parameters for adult patients. These include respiratory rate, which is usually between 12 to 18 breaths per minute, and tidal volume, which is between 6 to 8 milliliters per kilogram. Irregular breathing may be called tachypnea when respirations occur more than 20 times a minute, or bradypnea if the respiratory rate is less than 12 times a minute. Agonal breathing or agonal gasp are slow, irregular movements which may cause a gasping or snoring sound. These sounds are abnormal and may indicate cardiac arrest. Agonal breaths are not adequate for ventilation. The patient may also experience dyspnea or shortness of breath, which may be due to a variety of reasons. Most commonly, the patient may have an obstructed airway due to severe asthma, COPD, or a foreign body. This may also be seen in pulmonary edema or in cardiogenic etiologies such as heart malfunctions. Dyspnea may be a compensatory mechanism from the chemoreceptors, which are stimulated during hypoxemia or metabolic acidosis. Early signs of dyspnea may include anxiety and panic attacks, which may be followed by progressive signs including shortness of breath, retractions, agitation, or changes in mentation. Respiratory arrest is the complete cessation of breathing, while distress is defined as abnormalities in respiratory effort or rate. It is often characterized by an increase in respiratory rate, use of accessory muscles to breathe, wheezing or stridor, and agitation. Respiratory failure occurs when the body can no longer compensate for the lack of oxygen. This results in a decrease in respiratory effort despite a continued need for increased ventilation. The patient may become cool, cyanotic, and may become unresponsive. Breathing disorders are often characterized by type. Restrictive disorders occur when the patient has difficulty taking in enough air inside the lung. This occurs in interstitial lung disease, scoliosis, neuromuscular disorders, or marked obesity. Obstructive disorders mean the same volume of air in the lungs remains after exhalation. Common causes include COPD, asthma, or physical obstruction of the airway. You should refer to your manual for more detailed information. Respiratory arrest may be caused by a variety of etiologies. The first is a result of diminished respiratory drive. This may be drug-induced, as is the case in opioid overdoses. Opioids include fentanyl, oxycodone, or street drugs like heroin. This may also be caused by the ingestion of alcohol, barbiturates, or benzodiazepines. Diminished drive may also result from central nervous system abnormalities, including ischemic or hemorrhagic stroke, meningitis, or CNS malignancy. Finally, respiratory drive may decrease in patients who have too high or low glucose or pH levels. It should be a priority to assess blood sugars and gases at the earliest opportunity. Airway obstruction may also cause respiratory arrest. This includes obstruction of the upper airway, which is caused by a foreign body, vocal apparatus spasm or swelling, and laryngitis or epiglottitis, which is a true medical emergency. Lower airway obstructions may be caused by pneumonia, especially aspiration pneumonia, pulmonary edema, or obstructive disease. Finally, muscle weakness may also play a role in respiratory compromise. This may be caused by fatigue, which is often the result of increased respiratory rate due to acidemia. Neuromuscular disorders like spinal cord injuries, myasthenia gravis, or Guillain-Barré syndrome may cause increasing weakness. Finally, toxins like botulism may cause flaccid paralysis. It is important to distinguish the cause of respiratory issues in patients who are at risk for cardiac arrest or who are in respiratory arrest. Let's talk about the primary assessment and how it pertains to breathing. The first step in the primary assessment is always airway. Use the head tilt chin lift maneuver to open the airway and prevent the tongue from blocking the airway. Start by applying pressure to the forehead and chin so the patient's head tilts backwards. You should never perform this maneuver if you believe the patient may have sustained any kind of head or neck trauma. In the case of a known or suspected cervical spinal injury, you should perform a jaw thrust maneuver by manually pulling the jaw upward. Someone should help you hold C-spine immobilization while you perform the procedure. The next step in the algorithm is breathing. At this point, if the patient is not breathing, you should immediately begin CPR. There are several ways to ventilate a patient, including mouth-to-mouth and mouth-to-mask breathing. Mouth-to-mouth is often the quickest way to initiate rescue breaths, but you should consider your environment and the safety of doing so. Always use the safety equipment available to you. Use the head tilt chin lift to open the airway. Pinch the nose shut and take a normal breath. Seal your mouth around the patient's and blow for about 1 second. It is not necessary to blow a large amount of air into the patient. Just ensure you have good chest rise. Repeat one more breath, remembering that adult CPR is performed using 2 breaths after every cycle of 30 compressions. Rescue breaths should be delivered in less than 10 seconds. In many cases, especially if you work in a hospital or as a first responder, you will have a bag valve mask or a pocket mask. Pocket masks are used in the same way as mouth-to-mouth, except the rescuer blows into the mask, which is fitted tightly to the patient's mouth and nose. These masks have a one-way filter to protect the user. Artificial ventilation may also be achieved using a bag valve or BVM mask. This is a face mask attached to a ventilation bag. This is the most common method of providing rescue breaths during respiratory arrest. The goal is to deliver a stream of airflow near normal tidal volumes of 500 to 600 milliliters of air. This may not require a full squeeze of the bag. Check for chest rise. Do not overinflate the lungs. Use a C and E formation with your hands to help hold the mask tightly to the patient's face. The rescuer should be at the head of the bed. Don't forget to remove any pillows or blankets. If there are 2 rescuers present, one person can hold the mask like this while the other compresses the bag. Some patients may require 2 people to ventilate properly, including patients who do not have strong jaw lines or defining features like teeth. There are a variety of oxygen delivery devices you can use to help patients in any stage of respiratory distress or arrest. Low-flow devices like nasal cannulas and oxygen face masks should be used for patients who need small amounts of oxygen as evidenced by shortness of breath, lower than normal O2 saturations, or anxiety. High-flow oxygen devices include the high-flow nasal cannula, which can deliver up to 60 liters a minute, the Venturi mask, and the non-rebreather mask. For emergent use, the non-rebreather mask is often the most accessible high-flow oxygen therapy device. Supplemental oxygen supply may include individual tanks or flow meters in the wall. Always ensure your equipment is functioning properly before use. If the patient is breathing spontaneously and requires a small amount of supplementary oxygen, consider using a nasal cannula to keep oxygen saturations above 94%. Nasal cannulas can go up to 6 liters. For patients who require a larger amount of oxygen, consider using a non-rebreather face mask. The patient must still have spontaneous respirations. You should use a minimum of 10 to 15 liters with the mask. The bag attached is meant to function as a secondary reservoir of oxygen, which is not immediately inhaled. This reservoir helps the non-rebreather mask secure oxygen delivery of up to 95 to 100%. Be careful with delivery of any oxygen. Patients who are likely to have nausea or vomiting and may have diminished cough or gag reflexes could aspirate if they are unable to remove the mask. Some other advanced airway adjuncts include a laryngeal mask airway, or LMA. The supraglottic airways are often used for EMS transport where intubation may not be successful. It is inserted through the mouth and inflated over the glottis. Once inserted, the tube is inflated. The provider should be aware that removal of the device will likely result in vomiting. Providers should be prepared with suction to remove the tube, so it may be replaced with intubation. Other alternatives include a combitude, which has a double lumen and a balloon cuff for the larynx and esophagus, and the laryngeal tube, which features a large oropharyngeal balloon cuff. The laryngeal tube is easier to insert but does not provide protection from gastric contents. By far, the best airway for an unresponsive patient who needs rescue breathing is the endotracheal tube. This is a flexible rubber or plastic tube inserted into the trachea using a laryngoscope. It may be used with a bag mask device or may be used with a ventilator. The ET tube is technically challenging but provides a more secure and specific airway. It is sized for the patient and may be used as a long-term airway for several days if necessary. Capnography may also be used with an ET tube for both placement and continued monitoring. EMS2, as with any airway device, the provider should assess and reassess at regular intervals and after any position change or transfer. The DOPE mnemonic is used for troubleshooting airway adjunct issues. These include D for displacement of the airway, O for obstruction of the airway, which may be caused by kinking or aspiration, P for pneumothorax, which may be caused by either an existing or new pneumothorax, and finally E for equipment. If you believe your equipment is not functioning, return to using a bag valve mask until functionality is verified. In 2020, the COVID-19 pandemic brought a new virus with specific safety and resuscitation requirements. SARS-CoV-2 may result in severe acute respiratory syndrome, ARDS, and is transmitted via droplets and aerosols. Early signs and symptoms include fever, loss of appetite, fatigue, loss of taste or smell, shortness of breath, and cough. These symptoms may progress in some patients to severe respiratory distress, high fevers, kidney failure, and change in levels of consciousness. COVID should be suspected in any patient with a history of respiratory or flu-like symptoms. EMS or transport personnel should use personal protective equipment and should alert the destination of possible infection. Appropriate PPE includes N95 masks, eye protection such as goggles or face shields, disposable gloves, and isolation gowns. If the patient is able to tolerate a face mask, one should be applied as soon as possible. High-flow oxygen has been shown to improve outcomes, including the use of BiPAP or CPAP. However, these tools do increase the risk of transmission due to aerosol generation. Follow the guidelines of your local hospitals or regions. This concludes Chapter 2. In this chapter, you learned about important airway adjuncts and life-saving techniques for emergent delivery of oxygen. Early intervention is important for patient outcomes.